And remember this is just such a basic introduction to regional, because you're going to have a whole class next summer on regional anesthesia, and Dr. Shores usually teaches that. And then you're going to get deep in the weeds on it. So you're probably going to think that you need more details right now. You're going to have these deep questions that you are going to need to know, but are you going to need to know them for next week's exam? Probably not. So relax, it'll be okay. Remember, this is the introductory to it, and you will get more than enough details in your future, Dr. Schwartz. But what I'm going to try to do is basically go over the highlights. Now, Diana is a UNF grad, and she works at Halifax, and she is now the clinical coordinator there. So when your schedulers work with her and you get a clinical assignment there, she's the one that works with you, and she's like the representative for you and your class when you do your clinical rotations. She's totally awesome, and I'd like her to come do a lecture for you guys in your third semester in this course particularly, so you know her and you see her and you go, yeah, she's going to be at Halifax, and then you kind of already know a person before you get there. So that's why I like to have her do it. She always enjoys coming too, right? She wasn't able to do it. Gosh darn it, somebody has to work for a living around here. She has this slide, which I like. Long time ago, people who sacrificed their sleep and their family and food, laughter, and other joys of life were called saints. Now they're called, more specifically, SRNs. And we laugh, but we all know it's true. And you will be glad that you are living through this journey and making the sacrifices you're making now. And it does not get any easier in the next 2 years. It just keeps going. And the pace keeps increasing and the stress keeps getting higher, but it's worth it. And if you keep that goal in mind, you will get there. And again, you'll get there together. You gotta help each other. I like that slide. All right, we're gonna talk about regional anesthesia. So when we talk about regional, we talk about spinals. What's another way to say spinal?
Neuraxial.
Intrathecal. What else?
Neuraxial.
Neuraxial. What else? You heard of the SAB?
Subarachnoid.
Subarachnoid block. Okay. So we have epidurals. What's the difference between a spinal and an epidural?
The space.
The space. That is one thing that's very different. So one's got a little space, one's got a big space.
No, I mean.
Okay, this brings up another question then. Sometimes I forget the first question I asked because I end up with 5 questions. So if we're going to place either a spinal or epidural, I'm going to go through these different layers, right? The needle, whether I use a skinny little needle or a big fat needle, the big fat one would be to place what?
Epidural.
If it's a skinny needle, it'll be a
Spinal.
Okay, so we have that down. And there's specific gauges we use, so you should know what those specific gauges are. But right now, this is how I like to teach. Skinny needle, spinal, fat needle, epidural. Okay, so we're gonna, whichever one we use at this point, we're gonna start someplace. So I'm gonna do my measurement on the patient, and I've got my hands here. Where are they? Oh, I forgot, I brought my friend with me. Okay, so this is only a partial friend. This was a whole friend until I got a hold of them, and now this is what's left. Okay, so I got my hands here, right? This is the, okay, so if I want to figure out where I'm going to put that needle, whether it's a spinal or an epidural, what landmark is here? I heard 2 things. One of them is more specifically correct. So the line that goes across here, let's take a vote. I heard 2 numbers. L3. With confidence. L4. L5. Who doesn't know? Everybody should have confidence in that one. It is L4, but we think of it as L3-4. It goes usually, typically on most people, most anatomy, we say top of the crest goes to L4, and then that space where we're going to place the needle, whether it's a skinny needle for a, or a fat needle for a, it's going to go in that same space, 3, 4, 5. 3 and 14. All right, so we start, I've got where I'm going to put it. Now the first layer there, this stuff is the skin, right? Okay, so I've got the skin, and I push through with the needle. I've already cleaned it. I've already done all the prep. Push the needle through the skin. What's the next layer? What does subcu mean? Subcutaneous tissue, which is mostly like adipose type stuff, right? Okay, so I go through the skin, the subcu tissue, then the there's something after that, and I heard some right answers, and there were some, I'm not sure, and then there's a lot of
supraspinous ligament.
There's a lot of, don't make eye contact with me and ask me. I was a student, I get it. So, we're good putting the needle through. The first thing is skin, that's 1. And then the next thing is? Okay, 2 then?
Supraspinous ligament.
Supraspinous ligament. We're working really hard here. And then the next layer? Interspinous ligament. And then one further. Is that right?
Ligament what?
Ligamentum flavium.
So I have in my notes, well, that must be right then. Say again? You go through it. Number 1 is? Number 2 is? 3? 4? 5? With confidence?
Yes.
I don't remember, I think it's Latin, it could be Greek, Latin or Greek, whatever. So anyway, all right, we'll say that's correct. And then, epidural fat. Epidural fat.
What about epidural space?
Epidural fat.
Epidural space.
It's in her notes.
It's in the book, it's a picture. Okay, so the ligamentum flavum is it's really this thick tissue. It's, I don't know, it's kind of muscular, rubbery. And when you're going through, first you go through the skin, it's like and you feel it because it's kind of tough. So you go through the skin, then it's kind of soft. And as you feel it, you'll get these sensations. You go through, and then you hit the ligamentum flavum, and you're like almost like a pop, kind of. And once we get through there, there's this. It's not a real place. It's kind of like purgatory. It's not a real place. You're going one place or the other. But anyway, it's this space called the epidural space, and that's where we're going to put our catheter for placing an epidural catheter through that fat needle. We're going to place it in there, and then we're going to inject medicine in it. That local anesthetic is going to bathe the area. It's going to numb it up, and it's going to be an anesthetic for us. Now, if I wasn't doing an epidural, if I was doing that other thing with the skinny needle, and I go one more place, what's that thing? The dura.
Yeah.
So you're going to feel that one too. When you go through there, just more like a bigger pop, like a pop. And then what's going to happen? What's going to come out of the end of that little skinny needle?
Yes.
A little drip. And that needle's super skinny, it's real flexible. So you're thinking, you think, I'm there, and then you go, I must not be there, there's nothing coming out. But it takes a moment, because it's such a skinny needle, it takes a minute. Not a minute, but it takes a little bit for it to come through. So then you finally get this little drip, you know you're in the right place. Yes, that's a spinal. Now what if I want to do the spinal first or the epidural first? Can you put a fat needle through a skinny needle?
No.
No. Can you put a skinny needle through a fat needle?
Yes.
Maybe.
Okay.
So you're going to do the epidural first. And then if you think, so the nice thing about the epidural is you can bolus it. It takes longer for it to set up, but you can bolus it and hook it up to a pump and give them continuous medication. So that's like a labor epidural. They're awesome. You can either give boluses with a syringe, usually at 5 mLs at a time of this local anesthetic you choose. But it takes longer for it to set up, and it's not immediate, and epidurals tend to be more spotty or patchy, or sometimes they're fantastic and sometimes they're not so great. But they can work and they can be fantastic. So we use those for, a lot of times we'll use it for big belly cases. We'll do a thoracic epidural for labor and delivery. Of course, we use them in the lumbar. And if we think someone's going to go to a stat C-section, well, we might go ahead and do a spinal too. So we can take care of the immediate emergency, get that C-section taken care of, because they're going to be numb from there down. It's a super fast and dense block when you do a subarachnoid block, the spinal. As opposed to it doesn't take long for it to set up, but you use a very small amount of medication, very skinny needle, small amount of medication. It's it's like 1 to 2 mLs only per spinal. For an epidural, you're going to do 5 cc increments. It's going to take more. And you can give it boluses, or you can hook it up to a pump and use it for a longer period of time. What else do I want to say about that? That's what I'm going to say about that. Caudal blocks in the caudal region. I've never done one. I mean, I've read about them, and I know how to do it when I read it in the book. I've never had the opportunity to do one. And typically, I would say, if you do them, they're typically like in pediatric hospitals and pediatric cases. You still need, are you still responsible to know about it, because there could be board questions on it. And we might talk a little bit more about it. I'm sure you will talk about it in regional class next summer. We may mention it a little bit in pediatric next semester, but just, you're going to learn and know about it, but for today, I'm counting on what you've read. We're not going to spend much time talking about it, because your questions and your focus when you start doing observation, when you start doing clinicals, you're going to be adults. And we're going to do spinals and epidurals. Then we have regional blocks, upper extremity, lower extremity blocks. Now, I have not seen a head block. I have in football, but that's illegal. But intercostals are becoming much more popular. So regional anesthesia, we call it that because it depends on the region that you're doing, and there's all kinds of different techniques and ways to do it. Central blocks, neuraxial blocks, spinals, that's the subarachnoid block. Epidurals. I've never heard of one in the cervical area. It may be, they may have been done and people may do them, but I've not ever seen it. There is something to be said about that, though, when we talk about where we place it. Because of the curvature of the spine, when you place it, look at these thoracic vertebrae, they're like really angled, right? Super angled. So when you put it in, you've got to put it in, you're going to be here with the needle kind of going like this. When you put a lumbar in, look at all that space in there. You're going to be putting in, it's still at an angle, but not much, where this one's more like this. I'm exaggerating. This one's more like this. So there's still a little angle up caudally towards the head, but it's different. So thoracic ones we use a lot, we'll use those for big belly cases. Sometimes they'll place them post-operatively, not pre-operatively, just depends. But the first ones you'll probably learn to do, the ones you want to learn to do first probably are spinals. Because they're pretty easy, you know you're in the right spot. And you get an immediate gratification, the patient gets taken care of right away. You know you're in the right place, you know to put the medicine in, it works fast, so you're like, man, these are awesome. And then the epidurals, because of the techniques that we use to do it, it's a little more challenging. Sometimes they work fantastic, sometimes they don't. But the more you do them, the better you get. And then again, we have the peripheral blocks. Most of the ones you'll see will be for shoulder surgeries and hip and knee surgeries, typically. Maybe ankle surgeries as well. How do we decide if we're going to do regional or not? Because we've got general anesthesia, we've got monitored anesthesia care, we've got regional. So which one are we going to use, or are we going to combine some together? You have to make those decisions, and you're going to be the expert on that. But it depends on the kind of surgery the patient's having. It depends on the patient's preference. Because if they refuse to have regional, you do not want to do one, even if you think that's the best thing to do. You don't want to do it if they refuse. Now, you may be able to possibly, I won't say talk them into it, but you may be able to present some evidence of why it's the safest thing to do to take care of them, and then they may change their mind. But if someone absolutely refuses, you don't want to do it. It's contraindicated. You can even, is it assault or battery? I don't know, one or the other. Some surgeons want a bunch of regional, like if you have these orthopedic surgeons that They want everybody to get a knee block. And then others are like, no, I'm gonna do that periarticular block. When they make the incision, they go and they do this kind of like a localized thing. Doesn't work as well as what we do, but I will say this, the patients can mobilize and they have control of their legs. They can move and ambulate much quicker. And a lot of times they can get out of the hospital a day earlier than if we do a regional. So a lot of orthopedic surgeons are doing their own little periarticular thing intra-op. And sometimes they'll do maybe an adductor canal block with it. But a lot of times they're not doing them. It just depends on the surgeon. So in my facility, we have, I don't know how many orthopods, we probably have 10 or 12. And we have a little chart that this surgeon wants with this kind of surgery, they want this block or not. And that's how we have to do it. So you have to know them, you have to ask them. You can't just assume that, well, we're doing a knee surgery, this is how we do it. But as you go to your clinical sites, you'll learn because your peers or the CRNA you're working with will tell you, oh, this surgeon likes to do this or do that. Regional blocks are really cool to do. They're fun. And when I started doing them and learning to do them, we did it the old nerve stimulator way. And they didn't do much ultrasound. Now almost everything's ultrasound. So I would suggest learning both ways if you have the opportunity. Because sometimes, let's say a facility has 2 ultrasound machines and there's like 5 knees that are going back at the same time or something. You can still do it the old way and still be effective. It's good, I think, to learn both techniques. Case selection again. A lot of times we do spinals or epidurals for C-sections, labor, cystos, urology procedures. We'll do the peripheral blocks for the orthopods. Sometimes it just depends on the patient. Like if the patient's super sick, people will say, well, we'll just do a regional. Like it's less than general. Sometimes it is better for the patient, sometimes it's not. Evidence really shows that one technique is not necessarily better than another. But depending on the patient, depending on the procedure, depending on the surgeon, depending on you and your abilities, one technique might be better over the other. But I would say the general thinking out there in the world is that all spinals and epidurals are better for a patient that's super sick. Sometimes that is true, but it's not always true. Because a person's blood pressure can drop real fast with a spinal or an epidural. And that would be the same problem as when you gave propofol or etomidate and they dilate out, or you're using gas, things dilate out and your blood pressure drops. So most of the evidence still says they're all about the same, but there's a lot of factors that depend on why one might be better than another on a particular situation. Absolute contraindications, I would know these. Number 1, patient refusal. If you're getting ready to put that needle in, skinny needle, or fat needle, if there's an infection there, you don't want to do it. If that person has bleeding problems of one sort or another, if they're on Coumadin or Plavix and they have to be off it for a certain number of hours or days, depending on what the drug, there's different drugs, so you have to know what that protocol is. And also if someone has like intracranial pressure, then we can say that we're not going to do spinals or epidurals on those people. But with this patient refusal, if you truly think it's the safest thing for them and you've presented your evidence, a lot of times they'll say, well, I don't really want to do anything. Well, okay, well, here are the choices, because we have to have this procedure done, or you know the outcome of that. You're here, it has to be done. Then you can refuse that too, because then we can consult hospice and we can take care of that too. That's okay too, we can do that. People have those choices. But as far as spinals, if someone says, or an epidural, regional, if someone says, no, absolutely not, you're not sticking a needle in my back, okay. But I still say, well, here's why I think it's a good idea for you. And they'll say, nope, still don't want to. Okay, well, then we're going to do general anesthesia. Here are the risks involved here. Just switch right over. You can do it. Consent them for everything. And even when they say, yes, I want to have a spinal, I consent them for general too. Because you never know where you're going to have to convert, right? And they go, oh, I'm going to sue you because you said we were going to do this with a spinal, and then I woke up. I wasn't supposed to go to sleep. Okay. I consent them for everything pretty much. That way you're covered. Contraindications, if it's appropriate for the patient, again, if there's a small infection but it's to the side, maybe, if there's redness or cellulitis around where I'm going to put a needle, I'm not doing it. That's just my own personal opinion. I'm not doing it. If someone is super dehydrated, we probably don't want to do it. And a lot of times they'll do boluses before we do a spinal or an epidural, like 500 mLs to a liter, to get intravascularly get them tanked up. But some people can't handle that kind of fluid bolus. So you have to weigh the pros and cons. If someone has chronic low back pain, I usually consider that a contraindication, because something you do could inflame that or make it worse, and then of course they're going to blame you for it. And I don't want to put myself in that position. What about tattoos? People ask me about that, because a lot of people get tattoos in that perfect spot. And if you're going to get one of those tattoos in that spot, if I were you, don't put it in the L3, 4, 4, 5 place, because that's our backup to the backup plan. So put it above L1, and then you'll be all right, because we're not going to probably place one, okay? Just, if you're thinking about your tattoos and you're going to put them in the backside, then that's probably what I do. We prefer not to have to place the needle through the ink, because technically you can put that ink in either the epidural space or the subarachnoid space. But I guess some of the literature is saying that there's not enough people that we studied that we know for sure, but it seems relatively safe as long as the tattoo is not new. So if it's new, and I don't know what it means by that, I would say at least 3 or 4 or 5 months old. I wouldn't do it. And then you get people that, they have all sleeves and all this stuff, and you're like, I don't even know where to start an IV. So if you're going to get a tattoo, take your best vein and have like 2 little lines there, and then say, that's where you put it in between those 2 lines. Help a brother or sister out. Things you have to watch out for when you think about doing regional. If somebody has 3rd-degree block, heart block, and they don't have a pacer, I wouldn't do it. Now, even if your ACLS skills are fantastic, I wouldn't do it. If they have a pacemaker, they're probably okay, but you still have to really proceed with caution, because those are the people who are going to tank real fast. By that I mean blood pressure is going to drop, heart rate is going to drop, and they're going to be really hard to deal with. And then anybody who has a cardiac status where they have some fixed issues, where their heart's not doing what it's supposed to do, and there's stenosis around there, that could be a real problem too. Real hard to deal with. Who's a candidate? Well, you look at people and you see that they have respiratory issues. If they have serious respiratory issues, no matter what kind of anesthesia we do, it's going to be a problem, right? But if they have problems breathing, and we can do a spinal or epidural, it might be better than putting them asleep. It might do better. If they're on home O2 and their normal O2 sets like 88, that's normal high for them. I probably don't want to do general anesthesia on that person unless I absolutely have to, because they're already in a deficit as far as oxygenation. But it depends on how you see them, what's going on, what procedure they're having. So you have to consider everything. Now there's some people that are just afraid of going to sleep for general anesthesia. Man, I'm like, give me the good sleep. Most people are that way. They're like, yeah, I just want to get some good rest. Because most people are nervous the night before surgery, right? And they didn't sleep very well. And you just say, you're going to get the best rest you've had in a long time. They go, just make sure I wake up. I go, I will do my best. That's the plan. That is the plan. But sometimes you can, again, I don't like to say talk people into it, but you can say, I know you're frightened, and that's a normal reaction. Because you lose control. But it's very similar to when you go to sleep at night. We give you some medicine, you gently just drift off to sleep, and then you gently wake up. They may wake up frantically, but I'm going to tell them they're going to wake up gently. I'm going to plant that seed. And sometimes they'll say, well, okay. But if they don't want to, because if they're afraid of general anesthesia, then hey, well, we have these other things we can do that will help you, that should be able to make you comfortable. The problems with spinal sometimes, is that, especially if you're at a training institution, they might last about an hour and a half to 2 hours. And what if that resident surgeon is, how long is this going to take? They say, oh, no more than an hour and a half, 2 hours. And you're like, okay, we'll do a spinal. Perfect. And about an hour and a hal's going by, and you're like, how are we doing? You look over the rate, you're like, there's no way we can be done in 30 minutes. Like, okay. Then you start thinking, let's see, ketamine drip, propofol drip, like what else can I do? Because this spinal is going to be wearing off. And here I am. Am I going to have to go into general to finish this? Or can they just stay, like, can we do a propofol drip? Like, what can I do? That's the problem sometimes with the spinals is they're awesome. They're quick, they're dense, really great, but they only last a relatively short period of time, especially compared to the surgery if it lasts a little bit longer than the surgeon. You know, when the surgeon's sewing and they say, oh, I only need 10 minutes, and it's like 30 minutes later, you're like, they go, oh, the patient's moving. I'm like, you told me to wake, you told me it was going to take this 10 minutes. Well, I planned my wake up 10 minutes. No, okay. Anybody that has an obviously difficult airway, or somebody that, if we did a case with somebody in the hospital and they had a difficult airway, anesthesia folks will give them what they call a difficult airway letter to take home and to give to any of their other anesthesia providers when they have other procedures done. To say, I got this last time, the difficult airway letter, and you're like, okay. If there are no difficult airway, you can look at them and go, well, this is something we really need to do general anesthesia, so you're going to get your difficult airway cart, you're going to be ready and plan, have a plan, let that patient know you're going to take good care of them. Now that we know, we have the equipment to take care of you well. Or you might go, this is a procedure that we can do a spinal or an epidural on, and you should be very comfortable. Awesome. Now, sometimes people that are afraid of general anesthesia are not afraid of a little Merced. Do you drink alcohol? Yes, I do. Okay, this is like having a drink or two. One patient told me I gave him 2 milligrams of Merced. They said, oh, this is like 2 shots of tequila. I can't confirm nor deny that, but I believe it's to be true. Type of blocks, topical blocks. A lot of the eye cases you might do at different centers, surgery centers, as well as in hospitals or same-day surgeries. They'll do topical, which is pretty cool, except your role in that is basically monitoring vital signs, and you go, oh, who wants to do this? I say everybody does, because sometimes those vital signs that you're monitoring may be way high blood pressure, way low blood pressure, low heart rate. You're there to take care of them, make sure they're breathing and they're hemodynamically stable. So sometimes people say, why do we even have anesthesia? I will tell you why, because the eye guys, the ophthalmologists that are doing these surgeries, they would just get anybody to do it if they thought it was safe to do so, right? They don't think it's that safe to do so, even though it's topical, or they just numb the eye and do their thing. They feel like they need to have us there, so we're there. Yeah, oh, totally. And, oh, do you remember, you know what that's called when somebody sticks their thumb in a person's eye, there's a big reflex that takes place? Okay, there is a full-on response. So if someone's going to jump you and like they want to take your money or whatever, poke them in the eye. You might feel, or you can always use the Vulcan grip. That works too. I have found that works pretty well too. All right, different types of blocks. Something that's important. You're going to do some eye cases one of your first days in the OR, and you're going to get ready to set the room up. How are you going to set the room up? How is it going to be different than a general case, for example, or a regional case, or anything? How is it different? Sometimes they come in a stretcher chair, maybe, so that might be different, the bed part. Are you going to prepare for the possibility of intubating somebody? Are you going to have all your emergency drugs ready? You prepare for the worst, hoping for the best. And people will say, I like the surgeons go, oh, I'm just taking a little bunion off the toe, or I'm just taking a little piece of hardware out of the ankle. You're like, and they're trying to rush you, and you're like, but I have to prepare, like the worst thing can happen in there. I have to have my drugs ready, my emergency drugs. I have to be ready for doing an airway if I need to, because just put a mask on and give them a little sedation, they'll be fine. Okay, but you're not watching their breath and their heartbeat. I am, and I'm responsible for that. They're just there digging away, trying to get that little screw out or whatever they're trying to do. I'm trying to keep the person alive. So my point of that is, when you prepare for a room, you set it up like you're gonna be doing general, okay? Now, I'm not gonna say that everywhere you go, they're not gonna let you style at a tube and get it, open everything up, but have everything ready. Be prepared, always be mentally prepared for no matter what the case is. If it's a MAC case, or a general case, or a regional case, you are prepared to go to general anesthesia. And some facilities will have different protocols on how to do that. What I do is I style at a tube, and I have a MAC blade ready, because that's my early blade of choice. And people make fun of me because they'll say, you don't use a Miller blade? I do, I don't like them. Too many epiglottii have flopped on me, I don't like it. And sometimes they're like, this much, not long enough. A Miller 3 is way too long, where you're going up, who knows, into the brain. And anyway, that's my own bias. But my point with that is, when you're setting up for a case, you're always setting up for every possibility that can happen. You have all your emergency drugs ready. You have everything ready that you might have to intubate, just in case. Topical blocks, I like this. Okay, we're just going to numb this area. Have you seen that stuff? Kind of, sort of like freezes your skin. You can use that for starting IVs. That stuff's pretty cool. Something E's, I forgot what it's called. Now there is Emla cream. We'll use that a lot of times with kids. So it's like a lidocaine mixture. It's a ointment that you put, and then you put like a Tegaderm on top. But it takes 20 to 30 minutes before it really works for a while. So you have to do it as soon as they come in the hospital. But you can do that, so and that helps when you can start then IVs on kids while they're awake. But they'll hold still. That's the hard part of kids. But the thing about topical blocks, again, we use them a lot with eyes, and we'll use them. Sometimes people will use lidocaine sprays or acetylcholine spray in the nose or the mouth, kind of a thing. But what happens is, sometimes people keep spraying and spraying and spraying and spraying, and then you could actually have local anesthetic toxicity. You could give them too much. Now, if you include what you did for topical, and let's say that, okay, now we're going to do local at the site, and we're going to do local here and local there and local here, and all of a sudden you've exceeded that toxicity level, then you could see seizures. You can have cardiac collapse. You can have all kinds of things. And you're just thinking, it's just topical. It may not be. The nice thing about topical, though, is it's easy. The Emla cream is really nice. I did that a lot when I was training, when we worked with pediatric patients at UF Health. But a lot of places don't use it too much because it just takes so long. Local block, small area. I like it. So that's why, did you ever, I don't know if you've noticed this or not, but surgeons, let's say they're going to do a laparoscopic case, and they're going to make like 3 or 4, maybe 5 little incisions about an inch long. They always put a little local in, they put a little local in, and then they make their incision. You would think, well, why? It doesn't matter. The patient's asleep. It does matter. Because if they don't, you're going to see a sympathetic response on the monitor. So they always put it in there. And then afterwards, when they're all finished, before they start the suture, they usually put some more in there. So you're grateful for that, because they need it right there at that site, and then you're going to deal mostly systemically with them when you give narcotics through your IV. I can't tell what part is that.
I thought they were laying on the lateral. I thought it was for, I think it's sort of the knee.
Could it be a shoulder?
I guess it could be a shoulder, but it looks like they're more going into.
My first thought was yours. I thought this was like a side, and then I'm like, well, the trocars are placed sort of like we would for a shoulder, but the shoulder wouldn't it be?
Yeah.
It doesn't.
They wouldn't be doing that. Right,
and then it looks like a knee, but if it is a knee, where in the heck's the patella?
Yeah, that's a shin. No.
I don't know. So I just gave up. I just started making up stories because I have no idea.
They had a mass on their lung.
And
they thought they could remove it.
Maybe they're doing something with a kidney. I don't really know.
Yeah.
That was a good guess, though, wasn't it? Could be the left kidney problem. Don't know what it is. Have you ever heard of the bear block? So again, who made this? Thought of this? Beard. Yeah, Dr. Beard, that's cool. So, yeah, you start the IV, you infiltrate it with like the lidocaine, the local anesthetic. You've got this tourniquet on, so it keeps the blood from going through. It's just right there, it's numbing everything up. But the problem is those only last like 20 minutes, maybe 30. And sometimes, again, the procedure, if it takes longer than that, you're in trouble. Then what you gonna do? Because let's say the case is so fast, in 5 minutes, you can't release that tourniquet yet. Or this person's body's gonna get this massive dose of local anesthetic, and then you're gonna get that toxicity thing. You don't wanna have to mess with that either. That makes for a bad day. So it works really well for certain procedures. It's pretty cool. But the tourniquet has to stay up until the local anesthetic has a chance to kind of wear off. I've probably only done less than 10. And where I work now, we don't do them. We have cases where we could do them, but we just don't. 'Cause they're kind of time consuming, and we don't. Yes?
I know that the treatment for local toxicity is intravitreal, right? What about like infusing intravitreal towards the end of the block to kind of like bind with the agent?
I don't know if with like specifically the beer block. I just don't know.
And if that would like decrease the
Yeah,
possibility of toxicity?
yeah, it probably would.
Isn't it expensive though?
It is super expensive.
Oh, okay. Yeah.
It is.
Well, maybe it may have.
The way I answer it in the Army, of course we would do that.
Yeah.
The Army, that's where they have like double. Yeah, it's being recorded. In the Army, it seems like the staffing is almost double what it is in a civilian hospital for CRNAs and anesthesiologists. It's not quite double, but it feels that way. And they're like, we just don't have enough people to do that. And I'm looking at them like, what?
All those
Like
O3s and above sitting at the desk, yeah, they can get in the room.
They have like, 3 or 4 people walking around, and you're like, what are they doing today? Like in my civilian world, we don't pay people to give us breaks. Your break is between one case and the other, and you're hoping to be able to go to the bathroom. Usually somebody comes in and breaks us out for lunch for 20 minutes or so, but it's not like I got a 30-minute lunch and I've got to go home or whatever. And if you're a 3 o'clock person, it's 3-ish.
Yeah.
Somewhere between 3 and 5. If you're a 5 o'clock person, it's probably between 5 and whenever. And they've gotten much better about it than in the old days. But our job is different. It's not the same mentality that you had when you're the ICU nurse and you clock in and you clock out. If you're a 12-hour shift, you're 7A, 7B, someone's coming at 7P to relieve you. And then at 7A, someone's coming to relieve you. In this thing, you are done when the work is done. You are not that regular nurses are not professionals, because they so are. We so are. But it's a different level of expectation. You're used to the clock in, clock out kind of thing, and it's not really that anymore. It's like you stay till the work gets done. And you'll get that sense while you're in school. It's really a fun transition. Peripheral nerve blocks. These are really fun and cool. When they work, they're really great. Sometimes you can do cases without anything but the block. And a lot of times we combine them with general as well. In the military, I took care of lots of folks that just wanted the block because they didn't want to go to sleep. They had some post-traumatic stress, and they were like, no, I want to be awake, I want to be in control, I don't want to go to sleep. Okay. And it's just really uncomfortable for you because you have to talk to them the whole time. Though I like to talk, it's just weird because I'm so used to having everybody asleep when I take care of them. And so when you have this person just like as mentally alert as you and I are, except a leg or an arm is numb, it's just kind of strange. Like, excuse me, I got to turn my back to you for a minute. Just kind of different. They're watching everything. But it is fun too, because I'm like, can you feel anything? I go, no. They can I watch? I'm like, no. Nope, can't watch that. Nope. If anybody gets something taken out, like again, shrapnel or screws or hardware, stuff like that, we usually save it for them and give it to them. So it's like a war wound. How do you want to show that stuff? It's like badge of courage. Okay, now what is this part? It looks pretty much like a knee, doesn't it? Is that the left or the right knee? Pretty much. You know what kind of blocks they're doing?
Safino something.
No, it's it's better right here.
I think that she mentioned
Could it be an adductor canal?
Oh, yeah.
Could it be a saphenous? Could it be a popliteal? I'm asking.
Popliteal was underneath.
Oh, good. It can't be that. You're right. It can't be that. Okay.
You could tell us.
Or you can YouTube every single knee block and see if you can figure it out. That's what I did when I was in my office. So I figure if I can do it, you can do it in your spare time, right? Okay, different kinds of blocks at the elbow. This is cool because they have drawn with markers the different anatomy, and that way you know where to go. What do you think the red stands for? Artery. Yeah, do you want to stick your needle in there, your stimulator? No. Okay. And the blue, a lot of times, will be a vein. The black, a lot of times, is the nerve. And then these dash lines are sometimes they're just like a plane kind of thing. Marking a plane, like an area, not like an airplane. If you look at the NYSORA websites, they have some pretty good videos. Plexus blocks. What are we talking about with plexus blocks? Brachial and? Sure. Is there another way? Maybe. So when you do these blocks, particularly I'm thinking for a shoulder surgery, sometimes when you do it, the side that you've done the block on, the patient starts getting these droopy eyes, almost looks like they're having a mini stroke almost. So when you do a block, let them know that those are normal things. That is a normal thing. Their eye might get all bloodshot, it might get pinpoint or smaller constricted pupil. That's called Horner's syndrome, the series of things that can happen. It happens on the side wherever the block is on when we're talking about shoulders. But let them know ahead of time. They're like, wow, because if it just all of a sudden they start feeling weird and they're like, oh, I think I'm having a stroke now. They're probably not having a stroke, they're probably having Horner's syndrome, which happens. Let them know it's normal, but you want to watch it to make sure it doesn't turn into something worse. Or the symptoms get so bad then it causes some other kind of problems. There's the brachial plexus. We want to numb those nerves so we can do the shoulder surgery. Yikes. I like central blocks. The advantages, they're usually pretty easy. Spinals, particularly epidurals, get easier as you do them. With the spinal, it's easy, it's quick, fast, dense block. The epidurals take longer to set up, 10, 15, maybe even 20 minutes sometimes. Larger doses for the epidural, smaller doses for the spinal. But you can also do this thing we call a high spinal, where it goes, oh yeah, let's talk about dermatome for a second. Okay, so the nipple line is called the intermammary line. That's what I like to call it. That's at thoracic, what number? 1, 2, 3, 4, through 12. 4, so you should know that. Then we've got the xiphoid process, and you can say 1 or 2 numbers and I'd accept it. It's at T7 or 6. And then you got the bottom of the ribs here, would probably be T, I don't know. Well, usually it's about T8, and then your umbilici or belly button, T10. So I would know those. The scapula has one too. The bottom of the scapula, T7. So typically the way I learn them, the bottom of the scapula T7, the xiphoid T6, intermammary line 4, bottom of the ribs 8, and then the umbilicus 10. Now, some books will argue with the nipple line will be 3 or 4, or the xiphoid will be 6 or 7. I did it with basically even numbers, except on the back I made it 7. That way I could keep track of it. There's another problem here sometimes with these blocks. We get the post-dural puncture headache. So that's when you're trying to do an epidural, and you end up doing a spinal. And you get this CSF leak, and when it leaks out, it ends up leaking out and then pulls kind of retracts the brain enough to cause this pressure, which causes this big, bad headache. The bummer with it is that when we use a spinal needle, it's a skinny little needle, right? When we use an epidural, it's a big fat needle. So when you do a post-dural puncture headache, you get that. You have a big fat needle where you made a big hole instead of a little skinny spinal needle hole. And you leak out that CSF, and that's what causes it. Do you know what the treatment is for that?
Blood patch.
Blood patch. And that's just showing a child where we have here's where the epidural was placed, and then we have it taped up here. Usually that's like a little foamy type thing. They have like a tegaderm, they tape it, they want it to stay in place, and then it comes up over here, and then it'll be a little port, well then they can hook it up to like a pump and give that patient some good medication through it. Okay, spinal versus epidural versus general. Again, most of the evidence says there's really no difference in morbidity and mortality with which one you use in healthy patients. Now, in other populations, you can argue one being better than another. But in general, for healthy patients, it really doesn't make any difference. So what I want when I'm taking care of patients, I want them to be healthy. I only take care of healthy patients, right? Those are the only people that come to me. I'm grateful for that. So everyone is an ASA 1 that I see. Out of 50 people a week, maybe, I see. I probably don't see quite that. But I may see one ASA 1 every week or 2. Most people are ASA 2 or 3s that I see on an everyday basis. Occasionally I see 4s, occasionally 5s, and then sometimes 6. But I don't see very many 1s. Most people have something that makes them a 2. I see a lot of 2s and 3s, especially for elective surgeries. I do a lot of elective surgeries.
Did you say ASA 6?
7, 8, 9, 10. So we have ASA 1, then we have 4, and then what? 5.
5, isn't 5 donation? Or is
Yes,
6
5
donation?
5 years.
5.
And then we can put an E after it, which means
Emergency.
so they could be a 1E.
Sorry.
I can make, yeah, sorry.
You said it so.
I know.
6 is,
So you should know the advantages.
that's 6 or 4.
So what's 5 is critical.
Let's look at it right now.
Imminent.
So 1 is healthy. 2, they have condition. You need this for the exam, so it's okay to stop and do this. 1 is a healthy patient. 2, they have some kind of comorbidities going on, but they're controlled. Okay, and it might be a smoker. Anyone that smokes is put in that category. They go, well, all I do is smoke. I don't have anything else. I don't take any medicines. I'm healthy or whatever. I run marathons. Okay, but you smoke, so that puts you at risk. Higher risk than the person that doesn't smoke. So a 3, somebody that's not quite as well controlled, maybe.
Mild systemic disease.
So yeah, like hypertension. They take medicines, but maybe it's not perfectly regulated. Diabetes. Someone with obstructive sleep apnea that uses CPAP regularly. I usually make them 3s. Sometimes my colleagues make them 2s because they don't have any other issues, but I usually make an OSA person on CPAP A3. They're high risk. Then what's 4?
Severe systemic disease.
That's the person, like anyone that you do in a vascular case, they're 4s. Anyone that's on end-stage renal disease, they're 4s.
Without dialysis or with? Or is it
Usually when they're on dialysis.
on dialysis?
Yeah. If they have acute renal disease, they might be a 3, they might be a 4, but it just depends on what else is going on. And we actually discuss this on a regular basis. So I go and I assess the patient, my anesthesiologist has already seen them, and they say they're a 3, and I'm like, hey, I think they're a 2. Now they say, what do you think made them a 3? And they'll tell me, and I go, okay, just so I understand. But we discuss that, and sometimes I just always go with since I work with a supervisor, I always go with whatever they say. I don't argue it. I might with you if you and I are working together, but I won't argue with them. Say, okay, whatever you want to call it, we can do that. How about 2+? 3-, something like that.
So 5 was morbid bound patient with little chance of surviving, and then 6 was donation.
So we will say 6 is a real one, and that's when we do harvest. I've only done a few of those. Now they're pretty interesting cases. A lot of times they're done off hours, so people on call are doing them, or there's like a certain team of people that they get called in to do them, even the CMAs and stuff, so you might just do that person on call at the beginning of it. It's kind of a nice thing to do when it's not your regular normal business day, because if other folks, family members, or people waiting to have elective surgery see these folks coming in, it's a little disturbing, rightly so. Even though when you do donations, that's just an amazing, wonderful thing you can do and a way to give back to people, even though your organs are no longer good for you. So I definitely believe in organ donation. But it can be tough on people coming in for elective surgery going, what's going on there? So a lot of times those happen off hours. So we know 1, 2, 3, 4, 5, and 6. 7?
No.
And we put an E in front of it, just means it's an emergency, right? Know the differences, why we would select one over the other, spinal, general, epidural, MAC. Dermatomes, okay, this one right here is, what level? T4. Are you asking me or telling me? T4. We'll say the xiphoid, we'll say 6. I won't argue if you say 7. And what about the bottom of the ribs? And then belly button? Okay, know those. Oh. And then you'll need to know some of the ones here on the back side too. Do you want to get the next joke that Diana has on the slides? At the skin level, this is the segmental level, and why is that important? C8 is the cardiac accelerator fibers, T1 through 4. When they get blocked, that's not a good thing. Because if you take the brain or the brain stem and kind of anesthetize that, then you know who's making your heart beat, who's helping you breathe. Not necessarily a good thing. But it's important to know that T8, and you have those cardiac accelerator fibers. So I would be familiar enough with this. We talk about this word. Oh, we're talking about GI stuff. What else do I know? There it is. You know you're in anesthesia school and you know how it feels to take it in the S5 without surgery. So true and so bad, right? So bad. All right, as far as anatomy and physiology, I would expect that you would know the basic bones. And if I just had a picture of a bone, I think you should be able to tell me if it's a thoracic, cervical, or lumbar bone. And you're like, I don't remember I did that. You took anatomy and physiology to get into nursing school. I know it was a long time ago. But you can look pretty easy. The cervical ones are kind of short. The thoracic start having like these real big angles on them. And the lumbar starts getting kind of rounded here. Thoracic usually have more of an angle. You should be able to tell, and I would try to use one if I had a picture of one. Maybe I have a picture of a bone, one vertebrae, and you have to tell me what type it is and then label some of the parts, the spinous processes, etc. I would expect that you'd be able to do that. As well as if I said, tell me the journey, 1 through whatever number, from the outside to the inside to place a spinal. So we already kind of did that today, right? So be able to do that, or I might say to place an epidural. So be able to go through that step. They may be numbered, or I may just say have them listed, or I may have what are the first 3 steps of whatever, and then so be able to do that. Make sure you memorize that to know it. Make sure you can label those bones. Now something else that's important information to know is about cerebral spinal fluid. The total volume is usually about 150 in an adult. And we make 30 to 50 cc's that's in the cord at any given time. The pH value of it, approximately what it is. And then we make about 30 cc's an hour. Who knew? Where does it go? Like, how does it get used up? I don't know. It does. But your whole CSF, the whole system, all that liquid gets replaced every 3 or 4 hours. The body's an amazing thing. Know where the spinal cord begins and ends in an adult and an infant. And that becomes significant when you're going to place these spinals and epidurals. In an adult, where does it end?
L1.
I heard L1, 2, and 3. One of those is correct.
L1.
Okay, who says L3? L2? L1? See, confidence, straight up. Okay, L1 is correct, and then what are the nerves that go below that? So that's where we're placing our needle when we place it, and why don't we get a lot of nerve damage? Because those things are basically floating, moving around in the CSF, and so they just kind of move out of the way. You ever see the old movies where they have like the hippie bead doors or like little drapes? They just you just open them up and push through. It's kind of like that. You just you push through it, it's out of the way. You can still cause nerve damage, but it's not as likely. But if you try to place a spinal at T12, you could paralyze that person. Question?
If you do a caudal block, doesn't the patient lose control of their bowels and everything?
They could. They could also do that when you do a lumbar block. And urinary retention is one of the issues that people can have, and that's one of the things you would let them know. It's possibly difficult for you to void. Most people don't have any problem once sensation comes back to void, but sometimes they have to go, they have to either get a straight cap before they leave the hospital, or sometimes they have to come back to the hospital to get that emptied. So it's a risk involved with regional anesthesia. It could happen. Know the difference between these words. This will trip you up on an exam. The difference between a spinal cord, a canal, or a column. You know the difference. The cord is a nerve, right? The canal is the space the cord goes through, so it's like the hole, and then the column would be the bone, okay? The spine part. I would suggest that you know how many of each there are. So how many cervical are there? Nerve? Good question. Am I asking nerves? I just said how many cervical are there? Are you talking about bones or nerves? Because they're different. I would know both. So I would be specific in a question. I would say how many cervical nerves are there? How many cervical bones are there? Or how many bones in the cervical area? How many in thoracic? So you need to know if it's bones or nerves, and then you can answer those questions. So study them so you know those. And don't let that trip you up. Man, that happens sometimes on an exam. You think, I know this one? Because you know I'm going to have both answers there, right? You know I am. Maybe. All right. I want you to review the anatomy and physiology of this as far as the spinal cord, the gray and the white matter. You know that some fibers have sheaths around them that are myelinated, some are unmyelinated. Know about these different tracks. We have ascending and descending, and what happens, what's sensory, what's motor. And here, are we talking about cord or column? Column. Okay, so we're talking about bones here. So how many cervical? Wow. I don't usually have to teach this lady. It's a new word. I like it though. It's good. I'll find a way to apply it somehow. How many cervical vertebrae are there? 7. How many thoracic?
12.
How many lumbar?
5.
How many sacral? Fused.
Yeah.
Usually we say 5, but it could be different. But and then how many of the coccyx? 1. Okay, it's all fused together. Okay. Wow, this is important, and I would know. Okay, here's the picture, and then the next few slides kind of explain it. So I would be able to do a general explanation. You've got white matter, you've got gray matter, you've got the dorsal root, you've got the ventral root, you've got the ganglion. And as you go through these, it will help explain this. So where's the primary reaction of local anesthetics? We say the nerve root. So whether it's a spinal or an epidural, that would be the answer to that question. You've got a dorsal root, you've got a ventral root, and know what, so dorsal carries all afferent signals heading into the brain and spinal cord, and then the ventral root carries all efferent heading out the periphery. So I would know that. You should know the different types of fibers, and I would specifically focus on alpha, B, and C. So A, B, and C. Know if they're myelinated, unmyelinated, know which ones are the fatter ones, which one are the skinnier ones, which one are the fast ones, which one are the slower ones. Does that make sense to you? And then what do they do? But I would focus those 3, alpha, A, B, C. I would focus on those. The others are certainly important.
Did you say the diameter or just know the size of that stick?
I would know the diameter. I just said small and big or skinny and fat, but I would know the diameter. Because I won't say skinny and fat on the test.
You said no A, B, and C, so that's the entire, right? So you're saying A
I'm
is
saying-
alpha, beta, gamma, delta, and then B. And
Really focus on this and these.
Oh, gotcha.
Mm.
Okay.
What do I want to say about this? We're talking about order of block. You've got sensory block, you've got sympathetic block, you've got motor block. So here's how that goes. You should know that the sympathetic, parasympathetic fibers are small, C fibers and B fibers. You should know this word pre-ganglionic, that means before the ganglion. And then afferent and efferent, know that. Sensory nerves are small. Know that it tells you right here, intermediate diameter fibers, C, A delta. It tells you what they do, and then the motor, they're the large, thick ones, big diameter. And then I would know which ones are faster and slower too. When we talk about blockade, I would learn, and you want to test, you say you've done a spinal, and you want to test how it's working. Okay, you put it in, and it's moving, and you want to know where it is. So usually you've got your you've got a sympathetic block in two levels, TWO, 2 levels below that you'll have your sensory, and 2 levels below that you'll have your motor. So if I'm going to test my block, I might say first, can you move your toes? And they're moving their toes. I don't even have a motor block yet. So if I don't have a motor block, do you think I have a sympathetic block? No. So I go, can you move your toes? They can't wiggle their toes. I'm like, oh, something's working. So then I'm going to take either an alcohol swab, break it open. You know how it feels cool because it evaporates real quickly? So that's a sensation. It's cool to temperature. So you can start testing it to see where can you feel this? Tell me when you can feel it. So you start here, they're like, they don't even know you're touching them. Then they go, oh, I feel something. Or you can take like a tongue depressor. I like to break them in 2. And you get like a scratchy end. And you don't want to hurt your patient. You're just testing the level. But you can do, it's kind of a scratchy, almost like a pin prick, but it's not that painful. And scratch and try that and see. Oh, okay. So then you get an idea where the level is. And the numbers you will use will be T4, T6, T8, T10. Oh, it may come together eventually, right? So, because I want to be able to know, because it needs to be at a certain level if we're going to do a certain type of surgery. Does that make sense? Yeah. Otherwise, the surgeon makes the incision, they go, ow, that's not good for you or them. Okay, so I would know the information on this slide. What's next? I would know the motor fibers arise from the motor neurons in the ventral horn. They're axons existing in the spinal cord via the ventral root. Those are important big words to know. And I'm not saying don't know the other stuff. I'm trying to expedite your focus. Somatic system contains incoming and outgoing neurons, right? So the incoming, afferent, sensory. Afferent and sensory, incoming, those words go together. And what do? They're nerves for pain. What's proprioception?
Where your body is.
Yeah, being aware, okay, being aware where you are. Pressure and touch. So the outgoing are afferent motor nerves, and they control your muscles, basically. And it could be, reflexive, or it could be on purpose. I'm going to move my leg now. But it's really great when you've done a block for someone, you go, okay, can you move your leg? And they're like, no. And I go, it's still there. They look and they go, yeah, it's still there. But they can't feel it anymore. And you're like, okay, now we're ready for surgical incision. Cool. We've got the autonomic nervous system. You know about those divisions. Sympathetic, fight or flight response. So sympathetic, stimulating, you got to run because the tiger's coming to get you and they're going to eat you. Or the parasympathetic, I just had a big meal. I'm just going to lay back, digest, and relax. I'm not too good at that. I'm trying to learn how to do that. Relax. Let my parasympathetic kick in. Fight or flight. Oh. What do we want here? I would know where the sympathetic nerves originate, yes. And the anatomy behind it, about the parasympathetic nerves also. We have these two different systems. They will be coming up, I'll show you. So we have the parasympathetic system, lots of ganglia in that. The parasympathetic system, they end in the organ that they innervate. So they'll end like in the liver, or they'll end in the spleen, or they'll end in the stomach. Stomach, yeah, because that's where I'm doing my digestion, because I just had this most awesome meal and I'm learning how to relax. So here we have the two systems, the craniosacral and the rest. So you've got, why do these two go together? I don't know. Your head and your backside, right? And then you've got everything in between, the thoracic area here. But notice that all of these end in those organs. They're going to have an effect on those organs. Yeah. Know the primary neurotransmitters for the sympathetic nervous system, norepi and dopamine. Parasympathetic system has nicotinic and muscarinic receptors, and know the receptors as well as the neurotransmitters of each of these. Spinal anesthesia also interrupts, sensory motor and sympathetic innervation. What happens, the local anesthetic was going to block these C fibers in the sympathetic system first, and then it's going to eventually go everywhere else. But when I'm testing for the level of my block, I can test if they can move, so I can tell if they have a motor block yet. I can test for either touch or coolness temperature. I can use that, break off my tongue blade and use that scratchy technique and see. Again, you don't want to make a mark on your patient, but having a little bit of a point does help, so you can tell if they can feel touch. And then the alcohol swab is more like a temperature kind of thing, they can tell. So here we go. The sympathetic block related to temperature, so I have my cool alcohol swab, the little scratchy tongue blade into sensory, or can they move? Can you move your arm? Can you feel this? Okay. Sympathetic is 2 levels above sensory, which is 2 levels above motor. So when we talk about dermatomes, those are the levels I'm talking about. Okay, so, glad I remembered this. I'm going to give you some questions. I may give you some questions. I just reviewed the example for this class, so it's all fresh in my head. I might say that we have a motor at T10. So what would be the sensory?
T.
If I give you 1, and I say, well, if I say at T4 we have this, what would be, okay, say T4 we have sensory, what would the motor be? T6. Or what would be, if I had sensory at let's say T10, what would be the sympathetic?
T8.
Okay, so 2 levels above. Okay? Yeah.
Does that depend on their position and the veracity and all of that?
Veracity, we're talking about spinals, yes. But that's how it gets there. I'm talking about once it's there and you've tested for it, and I know that I'm getting sensory at T6, then I'll ask you questions. What would the motor level be, or what would the sympathetic level be? Okay? But yes, that's the next batch of slides, I think. Yes?
Just the previous line, I'm getting a little squirry with the touch being sensory and the temp being sympathetic. Like, so temp, would it be essentially like you feel the cold? No?
Well, I usually use it for my sensory. I usually use it for sensory. Because it evaporates and feels cool, if the person feels the coolness, you can actually go, that might be sympathetic. But I typically use the scratch, and I usually use it for touch. Because I'll say, can you feel it? You know how alcohol pads are kind of scratchy? So I use it for the touch more than that. Question over here.
So if you were going in at like T6, the first thing that would go, like at that level, would be sympathetic.
Well, now where you put, okay, say your question.
The first thing that the first sensation that you'll lose.
Okay.
Sorry, did I know?
No, go ahead.
The first thing you'll lose is the sympathetic, because those are like the smallest fibers.
Yep.
And then
Love.
sensory, then motor.
Usually it's in that order, yes. But when you're testing to see, you might not, you're gonna find out what level it's at. So, and you can't usually tell. The way you're gonna test it, it's gonna be from the bottom up, actually, is how you're gonna know. And it's because you wanna get to, usually it's a higher level so that they can do the surgery, because most of the surgery is gonna happen below here. But as far as where it goes to fastest, it would be that. What you said. Yes, question.
So I think I confused myself. So you said you do on your block, and then you're going to ask your patient, can you move your toes?
Yep.
If they can still move their toes.
They don't have a motor block yet.
Right. But they could still have the other two because they come first before the motor.
Yeah, usually, yes. Yep. But I can't really test for that. I can't really test for that yet. But when you as it sets up, what you're going to do as you're testing, you're going to see they're going to lose movement, they're going to lose sensory, and they're going to lose sympathetic. But where it's going to go to first is actually the other direction as the medicine gets there. But how you're going to see it, how it's going to present itself when you're testing it, is going to be they're going to lose motor usually first, and then you're going to see how high it is. And wherever you decide, okay, the sensory is here, then I know the sympathetic is going to be 2 levels above that, and then the motor is going to be 2 levels below that.
Thank you.
I know it's clear as mud, right? So I do have questions that will tell you one of the levels, and then I'm going to ask you what would the other level be. I like to use sensory because the other one's going to be 2 levels above, and the other one's going to be 2 levels below. But I think you'll be okay. I think you'll be okay. If you're going to be doing some kind of intra-abdominal case, you want a level of T4 to T6. If you're going to do GU cases, lower abdominal, like let's put a suprapubic cap in or something like that, or a cysto case, T6-8, or even lower, we can do T8 to T10. If you're not sure, I would always go a little bit higher if you're not sure. Because you want to make sure that what you've done is going to cover that patient so they can be comfortable. You guys want to take a quick bathroom break? Then we'll come back and power out. Go ahead, take 5, quick bathroom break. So, for now, remember you're going to have a whole class in this for a whole semester, regional, next summer. So, I don't want to get too caught up in some of the details that I know you're dying to know. But it's not going to be on your exam Friday, okay? So, you do need to know it. But if you just read through the slides you have here with the basics and look at the charts that I've gotten, you'll be okay to have a basic understanding. What I'm looking for Friday's exam next week, basic understanding. And a lot of your questions that I appreciate that you want to know every detail. And trust me, you will. You will. But for this moment in your life, your sRNA life, I want to keep it simple so you understand some basic concepts too. Now there's still stuff you got to memorize, no doubt about it. But for this, I want you to have a basic understanding of some things. And I'm trying to keep it simpler in this moment because I want to make sure you have what you need for your exam Friday, okay? I don't want you to get too stuck in the weeds of the details that you will know, I promise you will. But I just want you to have basics for today so you'll be prepared for next Friday. Is that okay with you guys?
Yes.
I appreciate the fact that you want to know, you want to take your boards tomorrow. I appreciate that. However, I want to keep it as simple as I can, not to insult your intelligence, but to keep the amount of content for you in a more focused way so you can be successful on Friday's exam. That's my goal for today, okay? Now, do you need to know everything? Yes, eventually you'll need to know everything. But I want to, my job, I feel like my mission today, rather than have you just watch a podcast from last year, is to keep you focused so you'll be successful Friday. Is that okay with you guys? Will you forgive me if I don't give you every answer or every detail today? All right. Because I want you to pass. So one of the things I want to make sure you understand, these different levels, because I definitely have questions about that. Do you guys get that if I said, okay, you've got a sensory level at T6, what would be the motor level? 2 levels below, right? What would be the sensory level?
T6.
I said sensory was 6, so then the sympathetic would be?
Four.
Thank you. Okay. Basic enough. It's okay if you don't know immediately that it was a C fiber, delta fiber, it was a myelinated, unmyelinated, just because I don't have specific questions on the exam on that. Do you need to know it? You need to know it. It may show up somewhere. It could be on the file. But for next week, I want you to know, I'm trying to focus in on what I know you need to know to be successful in the exam, okay? Now, the chart that was earlier in the lecture, where it talked about the different fibers and the size and diameters, you should know, I mentioned you need to know that. But I'm not going to ask you, I'm not going to put these 2 things together and say, I'm not going to make this big convoluted question about putting all that together if you know the answer. It's going to be simpler than that. Okay? So if I ask you a question about the fibers, it would be, which fiber has the biggest diameter, or which one's the fastest? I might put a couple of those things together, and then you would have the few to choose from. Okay? I'll keep it simple. I'm not going to put that together with this for Friday. I hope I don't have to go change any questions. If I do that, I'm going to give everybody a free point, okay? I didn't do that, but okay. Something that you need to know about when you're doing spinals and epidurals is that a lot of times people are going to get hypotension. If you're in OB and you've done a labor epidural, and they go, I feel nauseous, just go ahead and give them some phenylephrine or ephedrine, because they are hypotensive. Treat it. Don't give them Zofran, that's not what they need. They're hypotensive because they're, because we just gave them medicine and they're dilating. So they get bradycardic, their cardiac output's dropped, their blood pressure drops, oh boy. So if you have a patient that says you've just done a spinal or an epidural, and they go, man, I feel really nauseous. Usually it's with spinals, because again, it's very fast, it's very dense. They'll go, man, I feel nauseous. Just, you're going to treat them with a pressor. Phenylephrine or ephedrine. Now, if somebody is also dehydrated or elderly, I keep changing that number and making it higher and higher every year, every birthday. Because elderly people tend to be more dehydrated, though they have more volume in some ways, they're more dehydrated, or they have a lower vascular resistance. Those people are going to have a more pronounced hypertension, so hypotension. So know that too, and that's why we typically, before we do a spinal or an epidural, we're going to give them a bolus of 5 mL of normal saline or LR. A lot of times normal saline, and or up to even a liter. Respiratory stuff that can happen. Well, if you get a high spinal, they can stop breathing. As soon as we get up to the diaphragm level, phrenic nerve, they can stop breathing. So does it mean you've killed the patient? No, it does not. But if you've done a high spinal, you better be prepared to intubate that patient, because now they're going to need to be on the vent. And it doesn't mean you did anything wrong. Some people will get a high spinal. Some people will. Doesn't mean you gave too much. Doesn't mean you did anything wrong. It could mean that. But it just could mean maybe the positioning, you did something with positioning where it changed and it went too high. But it can get too high as long as you recognize it and you know that you're going to probably have to intubate that patient. It's okay. You're prepared for it, right? We're just doing a spinal. We're just doing an epidural. But you're prepared to intubate. You already got the stuff ready. So now they've done a high spinal, so now it means you're going to have to treat that. Okay. What else do I want to say about that? If you keep the level below here, you're probably not going to have that issue. But sometimes you need a higher level, but because that's where the phrenic is, 6, 7-ish, your diaphragm, and that's where we can start getting into problems. So, spinals and locals. The distribution of local anesthetic and CSF depend on all these things, and you should know these things. So, how do we know where the level is going to go when we get a spinal? A spinal, a skinny needle or a fat needle? Okay, do you know what gauge that skinny needle is? You should know, so look that up if you don't know. As opposed to the epidural needle, which is what gauge? We know it's fat now. Nope. So look those up, because you should know those. there's different gauges, but there's a typical one that comes in the kit that's normal, yeah.
Can you leave a spinal catheter in for repeat
No.
access? Just like, no,
It's
just a one-time thing?
One-time shot in, pull it out. So, what is the level of a local, when you do local anesthesia with a spinal? It depends on voricity, and you know voricity is related to specific gravity and the relationship between that and the spinal CSF, right? Yeah, you do know that, because you read about that. Okay, the contour of the spinal cord. Oh yeah, how do I know? Because as soon as you do it, you're going to usually lay that patient down, right? So I'm going to knock someone down. Typically what I do. So we put the spinal in, and then we lay them down, and look at the spine, how it's curved, right? So there's going to be a low point and a high point. Huh. So we lay them down, and this local anesthetic is going through the. We did the spinal, it's going through the subarachnoid space, and this movement. Here's the low point. So if I do a reverse Trendelenburg, or I do Trendelenburg, my spinal, I don't want to do that. Or if I do reverse Trendelenburg, I might keep it where it's lower, so we're going to do a surgery somewhere down lower as opposed to higher. But the curve of the spine makes a difference on how that local anesthetic kind of settles in. Does that make sense? Okay, good. Oh dear, the position of the patient again in the first few minutes. So let's say I want to do, we're going to take a genital wart off. I know, I'm sorry. If I had one, I definitely would want to take it off. Okay, but so we do a spinal. So I'm going to do what's called a saddle block. So I'm going to keep them in a sitting position. So we've done the spinal, they're sitting there, because I want everything to go, like where your body would touch a saddle. I want that area to be numb, but I don't want to worry about high spinal. I'm not going to lay them down, I don't need to.
Right.
I'm just going to work on the genital area. So I'll do a saddle block. That's awesome. Get those words gone.
How long do you have to have them sitting up for?
Usually, if it's a spinal, it happens pretty quickly, but I usually do like 5 minutes or so, maybe 10. But they'll go, I don't feel anything down there. Okay, then we'll probably lay down, get them in a orthotomy, take care. Sometimes we'll do general anesthesia too. Sometimes we'll just do a little propofol drip. Sometimes we'll just do a little sedation, fentanyl and Versed. It just depends on the patient, surgeon, and what all they want. But the saddle block is full, but you don't have to lay them down. But typically when you put a spinal in, like when you're going to do a C-section, a stat C-section, you're going to put the spinal in, you're going to lay them right down. And they say, what? In about 2 minutes, they're like, I feel a little nauseous. I just give some phenylephrine or ephedrine because the pressure's they're dropping. So it depends on voricity, the contour of the spine, the position of the patient, what local anesthetic we use. Now there's all kinds of charts about the different ones we use. Some are long acting, some are short acting, some are intermediate acting. And then with each local anesthetic, we have different percentages, right? So there's lidocaine 1%, 4%. We have Marcaine, which is the same as bupivacaine. We have 0.25%, 0.5%, 0.75%, and all of those things make a difference. So, and then there are some other factors, but I would know, if I could ask a great essay question about what are the different factors of the level of a spinal. Voricity would be definitely one. Those would be the ones you would list. If I would. So we have different kinds of solutions. We have hyperbaric. And so I think of it this way, though this is not scientifically correct. We have hyperbaric, we have hypobaric, and we have isobaric. I think of isobaric as like being equal, kind of balanced and equal. So when I do a spinal with that, it's pretty much going to go where you put it unless you change that patient's position a lot. And hypobaric, I think of it as being light, so it kind of floats up. It's going to go higher. And hyperbaric, I kind of think of it as being heavy or full, and it's going to go lower. I know this doesn't make sense, right? So if we think of specific gravity, and We have isobaric, which would be just kind of equal, and we have hypobaric, which would be kind of lighter, and we have hyperbaric, which would be kind of heavier, so things are going to drop lower. So let's say I do a spinal, and I want to do like a hip surgery. So then I'm going to put them on their side because I want all that stuff to go down. You can decide, or you can just start them on their side, and you can do a spinal. And if you use a different kind of hyperbaric, isobaric, or hypobaric, depending on where you want the local anesthetic to go, and it's based on the porosity and of these solutions. For now, just know that. Is that okay? And know that the level and the distribution of local anesthetic is based on these types of characteristics. Okay? And then know hypo, iso, and hyperbaric. Is it going to stay where you put it? Is it going to go higher? Is it going to go lower? No, that's enough for the moment. Now, the dose you give is directly related to the amount, the volume, because it's going to spread. The turbulence, if you inject it slowly, there's not much turbulence, or if you went real fast, there's more turbulence. And your turbulence is with the liquid drug and the CSF. That's where the turbulence comes from. And then, again, the voricity. Nice. When we talk about dose and spinals, it's only going to be 1 or 2 cc's. 1 or 2 cc's. When we talk about epidurals, it's going to be 5, 10, even more. It takes more volume. If somebody has, if they have ascites, and there's a lot of intra-abdominal pressure in there, it's going to change how that drug, how it moves and where it goes. Same thing with the curvature of the spine. Depending on what drug we use, again, what's the duration of the drug? We have local anesthetics that are short-acting, intermediate, and long-acting. Sometimes, if you want to help ensure that your spinal is going to last long enough for that resident that's doing the surgery, we can put vasoconstrictors in there. You can put phenylephrine as well as epinephrine in there. It's a very tiny amount. When we do epinephrine, we usually do like a splash. We draw some up in a little syringe, and then we squirt it back out. So it's just kind of barely in there. It's a very, very small amount. And then we drop the 1 or 2 cc's within use. But that can help prolong your block. So I would know these factors that affect the level. Here's some medications, the types of surgery, the sensory level. So if we know the sensory level, and that's usually what I'm going to be testing with my little alcohol swab or my tongue blade. This gives you a good idea of what kind of drug you might use and what maybe percentage, how many milligrams, how many mics you might use. Position, very important. Shortly after injection, you're going to lay that person down. Like, what's the rush? Well, if you're doing a saddle block, there really isn't a rush. But otherwise, you do want to get that spread so you get the level high enough so that they can get the surgery done and you get done. So if your head is slightly down, it can push that level up pretty high, T4, T5. If you're in a level position, your spine and head, T6, T7. These are general guidelines, okay? Or if your head's slightly up. Okay, what else do we want to know? Oh, sometimes people have kyphosis or scoliosis, and that changes the curvature of the spine, which then can affect how your spinal is going to affect that patient. Again, pregnancy, ascites, big abdominal tumors, those things can affect it, the spread. Epidurals, though, work by diffusion. You need large volumes compared to spinals. And again, it's only going to go as high or as low as you put the amount of volume in. but you don't want to ever put more than usually 5, maybe 8. Sometimes people I've seen put 10 at a time, but I usually do 5 ml increments so I can see how the patient's going to respond. Because again, you can always add more, but you can't take it away. The problem with these, again, is it take a little while for them to take effect, and you're all in a hurry. You want to get all this done now. But I still use smaller increments, 5 to 10, I'll say, because some people do that, and then see what happens. But it does take a little bit longer. It's not like a spinal, where once you put it in, basically everything distal to the level of the block. This is more of a differential block, and it's dependent on the volume and the site of injection. So you do a thoracic one, you do a lumbar one, it's going to be different. So the nice thing about epidural, they don't have to run out, like a spinal runs out. An hour and a half, 2 hours, it's gone. Epidural, you can keep bolusing it, or you can hook it up to a pump and you can keep it going. Nice. So I like that. But a lot of times they're not as predictable. Again, sometimes they're spotty or patchy. They don't work as well. But I do like them because you can manage those big belly cases post-operatively. They keep the epidural in 1 or 2 days, sometimes 3 post-operatively, and it really helps keep that person moving and getting in the chair and a lot more comfortable. For OB, wow. I don't know what people did before. Well, I do know what they did before, but I don't like to think about it. All right, know these, right? From skin. They didn't, I don't have in here the sub-Q tissue, but I would expect you to include that if I asked you to write it out. Supraspinous ligament, interspinous ligament, ligament flavum. Then we've got that epidural space. It's not a real place, but it's a happy place. Then we've got the dura, then the arachnoid, subarachnoid space. Don't want to go any further than that. What's in the subarachnoid space? CSF. And once you find it, you actually pull back on the syringe. So you have a syringe and you've got the needle connected to it. You pull back and you get a little of that spinous, you've got your drug already in there. And you pull it back and you see the CSF swirl, and then you inject it.
So you said you don't want to go past the subarachnoid space, correct?
Yep.
So what happens if you go to the TMR?
Damage, and you can also have CSF leak on the other side.
That'd be really hard to.
It'd be pretty hard. You couldn't do a epidural blood patch.
Blood patch on that side.
No, I'm sure that's probably happened somewhere in life, but I've not ever heard of it happening. There's probably somebody did it somewhere. It hasn't been an SRNA UNF to my knowledge. Here's that, you were talking about like what drugs and how much and all that kind of stuff and what level. This little chart kind of helps sum that up. Now, I'm not expecting you to have this memorized for Friday's test, but it'll answer some of those questions you had maybe about, so if I use lidocaine, tetracaine, bupivacaine, okay, it tells you the concentration here, tells you the levels based on the dose, it tells you the volume, the onset, if you had epi added to it, if you didn't have epi added to it, kind of nice. So when we use spinals, we're going to typically, I've used a lot of bupivacaine because I've done almost the kits they have bupivacaine in it, and it's either like a 0.25 or 0.75, depending on what you're doing. I've used them mostly for OB. I don't do a lot of spinals now. I just don't get to do a lot. I really like them, man. Whenever I get a chance, I'm like, yeah, because you feel successful. It's not like you get too rusty with them. It's sort of like IVs. Like once you've done IVs, even if you haven't done them for a while, you're still pretty good at it, You get a little rusty, but not too bad. But epidurals, the technique is in the feel of it. You kind of lose that muscle sense of epidurals if you don't get to do them a lot. So spinals, man, whenever I get a chance, I like to do them. And our kits have bupivacaine in them, so I don't usually get extra. You can go get other drugs to put in it. I usually just take what's in the kit and just go with it. It probably has something to do with production pressure too, where I work. Let's go. Gotta get this one done. So we can get the next one done, go home. You can add these different things I mentioned earlier, but it can prolong the spinals for quite some time, and that's going to buy you time. And different places might have different protocols about what they use and how much they use. So I would, when you get ready to do these at your different clinical sites, I would just ask the CRNA you're working with or the anesthesiologist you're working with, how do we do it here? know something so that, you don't have a blank slate. Know something. I know that we can do this. Is that how we do it here? This is what I learned about. How do you guys, do you have a different protocol or do you have a different way of doing it? Complications, hypotension, just about always happens. High spinal hardly ever happens, but you always have to have it in the back of your mind to be ready to intubate somebody. When they are telling you they're nauseous, usually, I haven't seen them get sick, but they're going to. They start getting diaphoretic, they tell you they feel nauseous, I just start treating them with pressors, yep, And some of the problems, they can have urinary retention with these. Sometimes they get lower back discomfort, and again, the posterior puncture fluid can also happen. Here's another tip. When your staff asks you what's the mechanism of action for benzodiazepine, don't say magic. Though it is true. You better know more than that. I know it's a lot, and I also know that you're